Be sure to complete the practice exams for each of your classes in ExamSoft prior to the exam day. There is an announcement that has been placed in all classrooms. So just make sure you look back at that announcement, but complete all of the practice exams for each of your courses. I think all the passwords are Fortis O1 or either Fortis O2. But look in your classroom announcements for specifics, but know that you need to complete the practice exams for each of your courses. In addition to that, ensure that you have your ID, your two devices. You will need your chargers just in case. Just make sure that they're in reach. You will need a dry erase board. The exams are usually open 1 hour prior to start time. So go ahead and download the exam at that time. In the event that you have accommodations, be sure to remind or send that information to each of your professors. In addition to that, in the event that you want that exam proctored, you need to communicate that with your professor and your campus dean. That has to be coordinated, and there's a time requirement in order to coordinate that. I think those are all of our preliminaries for exams. So we'll just move on into looking at the content for exam 1. So the nursing process, it keeps us structured. It's like a structured way of communicating, looking at things so that we can provide that best care for our patients. And so through the nursing process, we each have different tasks. So while the LPN is not an independent practitioner, we do gather information independently during the assessment. We obtain the subjective information as well as the objective information. And then during the implementation phase, we work independently there as well. For example, we administer medications, we may administer tube feedings, we may reinforce teaching. Now, we work collaboratively with during the evaluation phase and during the planning phase. The registered nurse is who comes up with a diagnosis. And of course, the registered nurse uses NANDA. Those are nursing diagnoses. So be sure you know the nursing process, ADPI, assessment, diagnosis, planning, implementation. This is our action piece. And then evaluation. Who does what? This is just let you look at that same information in a different way. Again, the LPN functions in an independent role in the nursing process by collecting the data and implementing interventions. The registered nurse creates those nursing diagnoses. The LPN and the RN work together on the plan of care and then the evaluation part. We want to always think about safety with our patients. The environment, we want to consider the environment that they're in and also whatever is going on with our patients. We always want to consider that safety piece. Call lights in reach. Is the area well lit? We want to make sure that noises, for example, those different alarms going off, we want to ensure that we adhere to those alarms or tend to those alarms pretty quickly, because that in itself can interfere with communication, the background noise and the alarms, the odors and all of that. Before collaborating on the plan of care with the RN, the LPN must assess the client's understanding first. So we do want to gain an understanding of whether or not the patient, the client, know how much do they know about what's going on with them. What do they know about that diagnosis that they have been just given? That's our starting point, because we do want to include them in the plan of care. We do want to consider their preferences, and then we don't want to just write down that they're being non-compliant. It could be a matter of lack of understanding or understanding in a different way, which could go back to lack of understanding. But we want to, it's important to assess the client's understanding first. What do they know about that diagnosis? What do they know about that treatment? What are their expectations? And then you can provide honest information in an assertive way, not an aggressive way, but honest information in an assertive way. Okay, so doing the teaching, kind of mentioned this already. Who starts the teaching off? The RN does that initial patient teaching. And then we, the LPNs, we come back and reinforce. And of course, we're going to collaborate with the registered nurse. So who does what? So we have the two phases of the nursing process that the LPN works more independently, and then we reinforce. Those two parts are gathering that information and the action part, the implementation. So out of all the things that we do, we wear so many hats as a nurse, but the U.S. Department of Vocational Education has narrowed it down to these 4 terms to describe the scope of practice. Remember, the scope of practice is individualized by state. It's our to-do list. It is those things, those tasks that we can carry out, that we can perform lawfully. But the 4 terms that are used to describe the scope of practice is judge, recognize, determine, and appraise. If you think about it, we do a lot. We're critical thinking because we always want those best outcomes for our patients. So we're always thinking about, what is this? What does this mean? What do these results mean? Trying to keep our patients safe, trying to get them back to their optimal level. We're interacting with the others on the healthcare team. So those 4 terms: judge, appraise, determine. What was the other one? Recognize. Yeah, recognize. So we gather information during the assessment phase. This is one of the phases of the nursing process that we are more work independently. And so we're gathering that information. We're having that conversation. We're asking those open-ended questions, and we ask those more focused questions. And so the information that our client, our patient, our resident, they're called different things, depends on what setting we're in, is subjective. What information does the subject, that person, gives you? That is subjective information. And then objective information is that information that we gain from, listening to the blood pressure. We listen to that boom, boom. We're looking on the dial to see where that dial starts and stops at. We're palpating or touching the skin. And as a result of it, we can tell whether or not that skin is warm or dry. It has edema. Wound appearance, we measure, what does it look like? What does the area around it look like? So this is objective data. Objective data also includes the client's level, our description of the client's level of consciousness and their orientation. Some other objective data is maybe like an X-ray report, lab results. We're looking at the doctor's orders and we can see the list of medications. That is chart obtained objective data. But subjective, the subject, the person tells us that information. Mentioned early on about safety. We always want to think about safety. Keep our patients safe. We don't want them falling, acquiring other injuries to them, if they're coming in for our care, if they're under our care, we want to keep them safe. So we have to be thinking all the time. Clients complain of lightheadedness. What are some things, what's some education that we need to reinforce? What in that environment that we need to ensure that's there? Is this new? Is it new onset? Is it ongoing? So fall precautions. Someone that's lightheaded, they're at risk for falling. So we do want to ensure that those beds are in the lowest position, call lights are in reach, and that we provide that reality orientation as needed. So we can, so they can use those call lights, let them demonstrate how to push the bell and ask for assistance. Those non-skid socks, make sure that they have on those grip shoes. If they don't have the non-skid socks on, make sure they have on shoes that have grip under the bottom, not those flick shoes. If they have a issue with ambulation, their gait being steady or unsteady. Want to make sure that they're wearing good wearing shoes. For example, they may not need on flip-flops. They may need a shoe that ties up and make sure that those laces are tied. Do the person need assistance with ambulation? Do they need to be assessed by physical therapy? Do they need gait training? Do they need a roller walker or a cane or crutch? And then we want to see, well, trying to find out what's making them like it. We go with those vital signs to see if they're normal. Provide that information about changing positions slowly. And then 3 hours post-op, always consider the concept. The concept is the main concept here is safety. But then put it into context. We're asking you about someone that is 3 hours post-op. What things do you need to be thinking about to keep that person safe? So usually they've had 3 hours post-op, they've had some type of surgery. Those nerve endings, even that person, they're coming back around. Those nerve endings are waking up. So they're more than likely going to start experiencing pain. They're not going to want to move. So we want to encourage them to move, change positions, do that deep breathing, coughing. In order to prevent blood clots, we might have to administer an anticoagulant. And then those compression devices or those compression salves. And then, of course, we want to monitor those vital signs because there are some complications that could happen. We hope they don't, but they could happen after surgery. And those vital signs, even if that person orientation is not so that they can tell you, those vital signs will point you toward something's going on if they're abnormal. So respiratory difficulties. If a person is having problems breathing, gas exchange, what are some things we need to do? Get them to change that position, get them up, getting the head of the bed up, rolling that head of the bed up, unless it's contraindicated. Using that incentive spirometer, having them to do that deep breathing exercise. And we might have to put that person on oxygen. But just know all things respiratory, listening to those lung sounds, counting those respirations. What are those findings that we have? The LPN will most often reinforce the client teaching and notice changes needed to the plan of care during the implementation phase. So when you're in there doing that action part, performing that skill, you are going to pick up on what are those findings. The person, you're administering medications and the person doesn't know the medications. The person's having trouble swallowing the medications. So the person having trouble swallowing the medications, we may need to communicate to the healthcare provider that those medications, the medications might need to be a liquid, might need a crush order. So while you're in there performing or implementing interventions, you will gather more information. And from that, you will be able to determine what we're doing. Is this really working for this person? So we're administering Tylenol or some type of antipyretic. We're measuring it, plus we're checking the temperature. Is this temperature going down or is it going up? So nursing interventions are patient specific, but what the nurse will do to assist the client in reaching their goals in the identified outcomes. Okay. When we're collaborating with a registered nurse, we want to remember that we want to be measurable, realistic, and time specific with the interventions that we're doing. Who will do the interventions? The student nurse, the registered nurse, the LPN. When will they do it? Each shift at the first round, every 4 hours for 2 days. Be specific. What are we doing? Are we using a manual blood pressure cuff or are we using an automatic cuff? What are we doing? Be as specific and realistic and time specific as possible. Okay, let's doing a little knowledge check here. Which care plan will provide the most thorough, comprehensive care for the client?
Individualized care plan.
Okay. So we want to provide that individualized, unique, specific, all those mean individualized care for our patients. So when the facilities purchase these programs, these electronic programs, um, the packet comes with everything you can imagine. For example, we'll just take a medical diagnosis. We'll say high blood pressure, diabetes. So the program, when you open it up, it has everything from A to Z about hypertension or diabetes. All of those things might not apply to your patient. It might not even apply to the setting that you're in. So we go in and take out all those things. We remove all those options because all of those options do not apply to our patient because we need to make the care plan unique, individualized for our patients. Okay. We do want to focus on our clients' care needs. We want to include them in the plan of care. And then we want to consider what their preferences are. What is important to them? But first, we want to gain information about how much they know about their disease process. What do they really know? Okay. When we're communicating, we have open communication and closed communication. For the most part, closed communication is a simple yes or no. It's very short to the point. It is not detailed. It limits, but sometimes closed communication is what you need depending on what's going on at that moment in time. But open communication, it gives that person to elaborate and get more details. And then it allows you as the nurse to come back and ask those more focused questions about the information that they've given you. So, do you have pain? Pretty much yes or no. Can you describe your pain? This allows for that person to go into detail to get so that we can get more information. SBAR, what is this? It is an organized way of communicating information. That it eliminates the chance of us forgetting something when we're trying to communicate. So, what is that situation? What's the background information that the physician needs to know in order to make a recommendation or give that new order? Okay, so we're going to look at two slides on SBAR. One is how to use it for the physician call. Remember, we're there, we're the eyes, the feet, and everything for the patient. So we're that little lifeline. We're that go-between. All those things mean that, the patient's not calling the doctor. We as a nurse are calling the doctor. So when we're making that call, the physicians, they do want the information as brief and to the point, but they do need enough information to know what is going on and how to provide a best answer or solution for this patient. So for situation, what is the reason for the call? Why are we calling? Change in mental status, fever, medication error, lab result. Why are we calling this physician? And we want to include our name, the unit, the patient's name, and then the problem. What is the reason for the call? So I'm going to toggle back and forth to these two slides. So the physician, that's the situation. But if we're doing change of shift, you're just giving report. For example, you're going home and you're giving me report. So we pretty much know each other. So we're right there. So you don't have to give your name because more than likely you know your coworker. So, but we do want to give that admission date, the chief complaint, and then what their diagnosis was. Because see, the reason for this is using the SBAR this time is to change of shift. So the situation is a little different. Okay, so you do need to note the difference when we're just changing shifts. We're going home and we're turning our patients their care over to the next person. Whether we're calling the physician because something has changed, something's going on with our patient, and the situation is what that is. We do need to get some background information. What is their admitting diagnosis? What date were they there? Did they just, go home? Did they just arrive? Have they been there for, 2 or 3 days or weeks? So, and then what is their current status information? You always want to have those vital signs, those current vital signs, the medications that were just administered. You want to get those allergies, if they have IV fluids, and what is that cold status? Okay. When we're doing change of shift, it's pretty much almost the same, but we are given like the location of the IV if they have one. What was their diet? What was their mobility? Pain management strategy, and then the response to that intervention. Okay, so we're calling physician, the assessment part. What you think is going on based on the data findings. And, we're going to collaborate with the registered nurse as needed here. For example, is this life-threatening? What do we think is going on? The assessment part. So we're doing change of shift. We're giving those vital signs, the pain assessment, any labs, anything that they need to follow up on, any preventative measures, fall risk. Bring it to our attention. Hey, patient in 201, they're fall risk. They like to get up unassisted. Provide those reminders. Okay. And then recommendations. These are the goals of care, what needs to be done, including the consult. Do we need to bring physical therapy on board? Do we need a dietitian? Do we need to transfer this patient to a different level of care? Patients on med-surg. This patient needs to go to the ICU. Is this patient ready to be discharged? Okay. And then recommendations, goals of care, what needs to be done, education, and discharge needs. What are those things? So make sure that you know the difference when we're using SBAR. But SBAR is a way to communicate in a structured way. So we can use SBAR to do a handoff report, or use it for change of shift, or we can use it to communicate with the physician. Okay, are there any questions before I move forward?
No.
Okay. All righty. Okay, active listening. We want to ensure that the receiver actually receives the information that the sender sent. So active listening is needed. We want to let our clients finish what they're saying. We want to use those strategies here we'll talk about in just a few moments, just to make sure that the information that the sender sent is really the information that we understood. So we want to clarify. So the key factors in active listening: purpose is health-related reason for gathering data or giving information. We want to use all of our senses. We want to be paying attention to what we're hearing. What are we seeing the client's response? What's going on in the environment. So we want to be alert to different clues that nonverbal communication. The patient may be talking to us, but what nonverbal cues are we seeing as well? So these are active listening techniques to ensure that the information that the sender sends is not miscommunicated. So you do need to know what restating is. And this one right here, remaining silent, it just seems it's kind of difficult for us sometimes, but it is active listening, just being quiet. Even if, for example, if a patient, family members, the patient just passed away, or they have just received a diagnosis or, poor prognosis or something, it is okay to just remain, just let your being present, but not actively talking. Your presence allows them, that shows that you still do support them. So we want to restate, that's just repeating, clarifying, ask questions in response to the patient's statement to be sure that we understand. So ask those questions and reflecting, put it into our own words, the information that we receive. And then paraphrasing is expressing in our own words what we think the patient means. And so a lot of times our patients, they'll be talking with us, and we just want to use that minimum encouraging so that they will continue to give us information. So words like motioning that head, up and down, it signifies for that person to go on and and continue with the conversation. Will continue with expressing and telling us what they want us to know. And then summarizing, stating the main data you have gathered and validating allows the patient to correct any information when we summarize it. Because sometimes there's miscommunication. So these active listening techniques lessens the chance of miscommunication. Okay, these three right here usually are the ones that we get mixed up. So clarifying, let's look at the examples that they have. Patient says their chest hurts. And then we as a nurse say, tell me exactly where your chest hurts. Because sometimes what is said is really not what they mean. So if you say, tell me exactly, they'll give us more information. And then hopefully they'll even use some actions, like they'll point or put their hand on what side of the chest. Then you really know that they're talking about the chest and not their shoulder, because you'll be surprised, when they're communicating, things are said that's really not what was meant to be communicated. So that clarification. So restating, my chest hurts and I can't sleep at night. So the nurse response is, you have been unable to sleep at night because your chest hurts. So we're trying to see if the patient is saying the reason that they cannot sleep at night is because their chest hurts. Or are they stating right now they're having issues with their chest and discomfort, and then just adding in this detail about what happened last night? So we do want to restate that just to ensure, because you can get communication can get mixed up. Okay, paraphrasing. The patient says, I don't think I'm being told the truth about my condition. And the nurse replies, you believe you have not received all of the important information about your health condition. Because we do want to make sure that they have enough information to make an informed decision. Even if we have to ask that healthcare provider to come back in and talk back to them, even if we have to bring in other members of the healthcare team. So positive communication techniques. We want to develop that trust and openness and that rapport with our patients. Okay. We want to establish eye contact, but not that sustained eye contact or that glaring eye contact. That's actually aggressive and negative communication. But making that brief eye contact every now and then while you're talking to them, you want to keep your promises. If you say you're going to come back, go, for example, the example that I always use is they want ice in the water pitcher or the cup. And we get that water pitcher, that cup, and we go off, and then someone calls on us to do something else. So if we can't go back, you can delegate or ask a team member, well, hey, can you take this water pitcher back, this cup of ice back, or this juice back? Let's keep our promises. Using open communication. Again, looking at nonverbal, being aware of body language, our own body language. We're in doing a dressing change. The wound may have an odor or it may look unsightly, but be aware of the body, the nonverbal cues that you're making. Frowning, turning your head, fan in the air. So be aware of that. So there are factors that can affect communication. Early on, I mentioned all the noise, the alarms that might go off in different settings. A person doesn't feel well, they're trying to get rest, and all this noise. They're not focused on what you're trying to communicate with them. They're trying to get comfortable. So that's called situational influences, and it can affect communication. Make sure that information is in a person's first language. If my first language is German, and you're giving me some information that's in Spanish, that's not going to do me any good. So make sure that we are communicating in a way that people can understand. Our patients, for the most part, they're probably not going to be healthcare providers. So make sure that we're speaking in terms that they can understand. We have to go to school to learn these terms as a healthcare professional. So we want to speak in a language and with terms that they can understand. Now, negative communications, this one right here, giving advice. The patients are going to always ask, what do you think, nurse? Because you all have established this therapeutic relationship and they really value and trust you. So they're going to ask, well, what would you do, nurse? But we don't want to give her, we don't give advice. We want to ask them, well, hey, do you have enough information so that you can make an informed decision? Or do we need to get that dietitian back in here? Do we need to get the healthcare provider back in and talk with you? So we don't give advice. We're not giving false reassurances. Oh, everything's going to be okay. We don't say statements like that. We don't belittle. All of these are negative communication. Examples of negative communication. We do need to know assertive, aggressive, and non-assertive. So assertive is being positive, being honest, put, to the point, not beating around the bush or putting things in a way so that people can't understand it or so that they think that you're being dishonest with them. We're not passing a buck. We're taking care of whatever's going on. Now, non-assertive and passive is the opposite. So we're passing the buck. We're not, that patient's say that they need more information. Well, we'll let the next nurse do this for you. We want to go ahead and contact that healthcare provider and let them know, well, hey, your patient is saying that they need to talk with you again. We want to be assertive. We don't want to pass the buck and be passive. But of course, we don't want to be aggressive. We want to maintain professionalism. We want to be safe. So we want to watch be aware of our body language. Example that I just gave was leaning forward, those glaring eyes. That's considered aggressive. So, and our tone, the way we say things, just make sure that we're speaking clear and watching our space, that space. We don't want to be in people's personal space. Okay. So which behavior style is this? So you can come off mute. Which one is it? So we're looking to say which one is non-assertive, aggressive, and then assertive. So the first one is, which style would be used to advocate for the patient? So we are looking out for the patient. We are calling that doctor back in or letting them know that the patient wants to speak with them again. They can do it over the phone. They may even do a video conference. Which one is that?
Assertive.
Yes. Which style passes the buck?
Non-assertive or passive.
Okay. And then which style would be confrontation?
Aggressive.
Got it. Good. All right. See how we did? Okay. We did pretty good. Okay. Does anything contribute to the risk for workplace violence? We want to think about where we're located. The example I always give is, for the most part, healthcare facilities, they want their employees to park away from the facility, not close up, not in the best parts. So what that does in itself, it can put us at risk for something happening to us as we travel from the designated parking area to the actual facility. I know in some places, they have parking decks, they have parking areas, and they have shuttle services because, believe it or not, you just never know when someone's lurking out there. And so they have these vans and things, the shuttles that run pretty often. So that lessens the chance of someone being injured or something happening to someone. We have to also consider our clients too. If they have a head injury, if they're having a mental illness, what's the word I'm trying to say? A mental illness, not flare up, but crisis. Then they're probably not making the best decisions or thinking clearly. If they had a head injury, a lot of times they're not thinking clearly. And so they might be hearing things, seeing things. And so when you come, you're just trying to provide the best care for them, but they may think that you're a threat. So you want to be aware of that, be aware of the conditions, and then any assessment findings that could potentially might put you in harm's way. Okay. Sexual harassment. What should you do if you are the victim of sexual harassment? The first thing you want to do, if you are the target, you want to confront the person who is harassing you. Tell them assertively clearly that their behavior, the things that they're doing or saying is unwanted. You want to be firm, and then you want to make sure that your nonverbal and in your verbal they match up. Well, she or he was saying whatever, but then they were winking their eye at me. So no, we want to make sure the things that we're saying are nonverbal and our verbal they match. If we're saying no, this is unwanted. That verbal and nonverbal should match. Okay. So we do want to provide culturally competent care. So we do want to make sure that we gain knowledge and skills about our clients that we're taking care of. As long as what we're doing does not cause them any harm or us any harm, then we want to include some of those cultural practices in their care. The patient might want a person of faith to come in and be present or to perform some type of ritual. But as long as it's not causing us any harm, it's not violating any rules or anything, then we want to include that in their care. A patient might, because of their religious belief, they might refuse pain medication. It might ask for some examples of things that they can do that are non-pharmacological. So you might have to tell them about meditation, position changes, opening the blinds, closing the blinds, getting the room nice and dark. But a lot of times it just depends on their culture as to how they'll be receptive to some of their interventions. So for food preferences, what they eat for traditionally healthcare facilities pretty much serve those 3 meals at those specific times. But it does not mean that those meals that they serve, even though they've had a dietitian to look, because they have to make sure that those meals are nutritious. They have to make sure they have all the food groups recognized and all that stuff nice and balanced. But they also will have an alternate meal. So if a person have a preference or their religious belief that does not allow them to eat whatever it is that's being served on that menu, we need to talk and collaborate with the dietitian and see what is an alternate, even if it means changing the time. Some people, based on what their culture believes, they might not want breakfast at 7 a.m. It's usually, I think, the serve time for most facilities. They may eat breakfast later in the day, or their disease process, whatever's going on with them, that might not be the better time, but we want to provide that culturally competent care. We want to include the client's preferences and ensure that, it, like I said, it's not causing them any harm, us any harm, that we want to include that in their care. Negative effects on culture. We want to be careful with stereotyping, prejudice, discrimination, and ethnocentrism. Ethnocentrism, there's only one way, and that's my way. No. We want to include, our patients' preferences. We don't want to assume that all members of one specific group is this certain way. That's stereotyping. These are negative effects on culture. So we want to make sure that we're not being prejudiced. We have a patient that comes in almost toward the end of the month. Well, they're likely they'll probably run out of medications. But they still want to provide that best care and manage their care. So you may have those that come in certain times if you're working in the doctor's office or the emergency room. We still provide that best care. Maybe underinsured or no insurance, we still provide that best care for that patient. We're on the team, the healthcare team. There are many of us. Everybody is important. We all contribute to providing that best care for our client and promoting those positive outcomes for our clients. So the dietitian, all things nutritious, if they have alternate food preferences, they have food dislikes, we need to bring the dietitian team in. They're having problems swallowing, we may have to bring speech in. The patient's getting ready to be discharged. They are going to need some resources, Meals on Wheels. They might need a concentrator, healthcare equipment. So that social worker helps identify those different resources that are available. So when that patient goes home, we have these things so that patient can manage their care and take care of themselves. Everybody's role is important. So let's look at this. It says it's important for the nurse to accept the client's right to their belief, neither agree nor disagree with their choice, and respect their right to refuse treatment of medication. We don't try to change their mind. We just make sure they have enough information to make an informed decision. Where you're stating that you're hurting, I've noticed facial grimacing, you have this pain medication that's available. No, I don't want to take it because, my religious belief. Well, would you consider some, non-pharmacologic medicines? You want methods. You want to change your position. You want an extra blanket. You want to turn down the lights. We don't try to change their mind. They have a right to refuse it. We support that autonomy. If a client asks you to pray with them or perform a baptism, we can do that. We can perform that baptism and pray with them. Some clients may belong to a religion that does not believe in certain medical treatments. We don't ever want to assume what the client's choice will be. We allow them to make that decision. And we kind of already talked about the client may have different food preferences or times that they want to eat. We want to utilize the appropriate healthcare team member. We can't do everything, you all. We can't do it, even though they're going to come to you. But we want to identify those others that's on the healthcare team that can assist us. Be sure to go back through your classroom recordings. Be sure to, at a minimum, also look at the exam review links. The schedule for the exam reviews are in the announcement section, so make sure you look at those so that you can attend those that you can. Come with questions if you have those. Reach out to your professors in the event that you have a question about a concept. You can reach out via email. What else? And I've already went over making sure that you have your IDs, making sure that you complete those practice exams for every course that you have. Okay, I'm going to pause.